So we're going to start off with Zoe Kourtzi, who's a professor of experimental psychology in Cambridge, and her research interests include learning and plasticity and computational neuroscience. And she's going to talk today about AI for better brain and mental health. Thank you.
Thank you so much. Great, good morning, everybody. Really nice to be here and have an opportunity to talk to you about our work on using AI and machine learning methods for better brain and mental health. Now, I'm really sorry I missed the morning session, but I heard you had an amazing primer on this. So I'll go fast on the first few slides because you all know this. So what drives us really to look into models that allow us to do early prediction of brain and mental health disorders? We have growing global challenges to address. At least 1/3 of all disease burden comes from neurological and psychiatric conditions, and this is growing. Dementia recently became the leading cause of death in the UK, and we have a growing mental health crisis, especially in young people. But to our rescue has come a lot of amazing work and breakthrough in two disciplines that in my lab we are trying to put together. One of these disciplines is cognitive neuroscience. With the advent and really the revolution we experienced with imaging technology, we're able to open the black box of the mind and look non-invasively into the brain and start understanding the processes, the underlying processes that support behavior in health and disease. And that happened around 2000. I was young and less sleep deprived than what I am now. But in 2010, and after this, we've seen a revolution in data science, in machine learning, and that has provided us with amazing tools that really have revolutionized how we think about the human behavior and the human brain. And so the question that I'd like to ask today, and hopefully give you some evidence for, is how can we harness these revolutions, these breakthroughs, both in cognitive neuroscience and in machine learning and AI, to understand better the brain and to be able to predict and personalize treatments for brain and mental health disorders. And today I would like to give you an example of how we can do this in the space of dementia. Similar methods and tools can be developed and applied in several mental health disorders. And actually what we see in the space of brain and mental health disorders is that the reason it's so complex and the reason it provides such a huge challenge for both researchers and clinicians is because we see a lot of intertwined behaviors, causes, and we need treatments that look across symptoms. So can we use AI to predict dementia early? Why would we want to do this? Dementia is really a huge global challenge. Every 3 seconds, someone is diagnosed with dementia, and 50% of individuals with dementia are undiagnosed, and even worse, one could say, 20 to 30% of individuals are misdiagnosed. Now, every clinician I work with tells me that when a patient that has Alzheimer's disease walks into their clinic, they know. But where the challenge is really at the very early stages or even pre-symptomatic stages of the disease. Why would we want to predict early? Now, we started this work about 12 to 15 years ago. And at the time, every panel I appeared at and I asked for funding for this research, I got the same question. Why would we want to know, why would we want to predict dementia early, given that we do not have disease-modifying treatments? Now, this picture has really changed. In the last 18 months, we have the first drugs that show in clinical trials of phase 3 some success. They are approved for further investigation by the FDA, and this path is now looking more promising. The reason we want to be able to predict and diagnose early is, first, in research, we need to understand better disease processes, and that can happen if we can track the path of these neurodegenerative disorders from the beginning, before even they start. Second, we can do much more precise patient stratification if we start early. We can encourage lifestyle changes, and we know that 40% of dementias can be actually avoided, or symptoms can be delayed if we change lifestyle factors early, for example, diet, sleep, exercise. And finally, by diagnosing early, by predicting early, we can personalize further both the diagnostic and the treatment pathway. So that's why our program of work has really focused on this early prediction, on early diagnosis, hoping that we can make a difference to patients, to clinicians, but also potentially to clinical trials and drug discovery. But to be able to address this successfully, we have to build machine learning tools that meet these three main criteria. So machine learning really allows us to learn from a vast space of data, from huge data lakes, thanks to patients that give access to their data. These algorithms can really learn patterns from thousands and thousands of individuals, and it's really important that they are biologically informed. We need to ensure that what these algorithms learn are features, are markers that are clinically relevant. And it's really important to do this because we need these algorithms to be interpretable. We don't want to stay at the black box space. We need to be able to understand why a machine learning tool that could be used to inform in the diagnostic pathway or the treatment pathway has made a specific prediction. What are the specific markers that it has taken into account? What is the multiplexed information across markers that it has based this decision on? And finally, we need these tools to be interoperable. There's no good use for me to work just with clinicians at Addenbrooke's, just nearby my office in Cambridge, and build a tool that just serves the Addenbrooke's Memory Clinic. Dementia is a global challenge, and we need to build tools that are interoperable across people with diverse backgrounds, with diverse demographics. Really, we need to be able to address this global challenge. So we need to be able to build algorithms that generalize. This is a huge challenge for machine learning. Most of the algorithms will do really, really well in being trained and predict within the context which they are trained at. But generalizing into new contexts, into patients with different demographics, going from research data that could have all sorts of biases to clinical data that provide all the diversity of different clinical populations is a huge challenge for machine learning. So that's what I'd like to show you today. I'd like to show you how we built models that address these challenges and how these models can be developed further to actually have clinical utility and serve as tools that can really support clinicians in their decisions and judgments. So the first challenge when we work with dementia, as I said, is the early prediction. And in the space of early prediction, what happens in dementia is we have a continuum from health all the way to disease. In this case, we're looking primarily at Alzheimer's disease. The examples I'll show you come from Alzheimer's disease, mainly because it's the most prevalent type of dementia, and we have quite a lot of data. We now have a program of work that looks at many different types of dementia. Now, the challenge here is if we want to predict early, the markers that we have are not predictive. If we are looking at the late stages of dementia, we can look at tauopathies, we have PET, we have CSF, we have markers that can be more reliable and predictive. But if we want to look early, we are looking at predicting from cognitive data, we are looking at predictive from a basic structural MRI scan. Now, these data that early in the disease are not predictive by the naked eye. When we look at them, we cannot really make robust predictions about what will be the health trajectory of an individual. And just to give you an example, here are MRI scans, standard T1 structural scans that give us an idea about gray matter and white matter integrity in the brain. And what you see here, this is a scan from a healthy individual, and I'm sure you won't be surprised if I say that this is a scan from an Alzheimer's patient. But really, the challenge for us is, what about this scan? Is this the scan of a patient with Alzheimer's disease, or is it the scan of a healthy individual? This, in fact, is a scan from a patient that has been already diagnosed with mild cognitive impairment and may be on the pathway to Alzheimer's disease. And that's exactly the challenge that our models tackle. They take data like this at the early stages where the markers are not predictive, where the symptoms are not predictive of Alzheimer's pathology. They learn from a lot of data, rich data, and they try to predict reliably. And that's the type of models that we built. This is the framework. We built models that look at multimodal data. This is data from thousands of patients, and they span different data types. So we bring together brain scans, we bring together cognition, we look into genetic markers like APOE4, for example, or polygenic hazard scores. We look at biomarkers like tau and amyloid. When we have all of this rich data from research cohorts, we pull them together, we harmonize them. And the question really that we ask is not whether we have a healthy individual versus a patient of Alzheimer's disease. We want to ask the question of at that very early stage, pre-symptomatic or very early stages of mild cognitive impairment, can we predict who will remain stable and who will progress? So we are asking actually the algorithms to do a very fine discrimination. And to do this, we built mathematical frameworks that have the following kind of three components. One, the first component is we built the algorithms in the way that they extract relevant clinical markers, markers that have to do something with biology, something with pathology. We need to know that the models are grounded in biology. Second, we take these models and we make them as shallow and transparent as possible. There is no point in building models that are really deep, really complex, but not interpretable. There are many methods now that are developing in the machine learning space that allow us to look more into the interpretability, even of very deep models. Here, I'll show you an example of fairly shallow models, but how they are really interpretable. And we ask these models to make this classification, to tell us who will remain stable at that very early stage, who will progress. But we don't want to stay at that binary classification, because this binary classification risks misdiagnosis. When these models put a boundary and they separate people into stable versus progressive, people around the boundary are actually at risk of misdiagnosis. And we want to reduce this misdiagnosis as much as possible. We know that already we have up to 30 to 35% misdiagnosis at a very early stage, and our models strive really to reduce this misdiagnosis. So to be able to reduce the misdiagnosis, then we moved into what we call a trajectory modeling approach. We extract indices, markers of these models. Now, these are model-derived markers. It's not just one predictor. It's not just one feature or biological marker. It's actually information extracted from the models that is based on this multimodal space that we have built. And these indices allow us to see how people will move over time in their own health, brain health, cognitive health trajectory. So let me tell you a little bit over the data. So the first step, as I said, we work with MRI scans. We bring them together with other different data types, and we look for markers in the brain that actually are biologically relevant. And you won't be surprised if I tell you that when we analyze the scans and we look at which parts of the brain relate to cognitive decline, we see very strongly that the models pick up features around the entorhinal cortex. Now, none of you will be surprised, but for us, this was a great validation that our models are actually are relying on features that are biologically relevant. Please keep this in mind. We believe that this is one of the main reasons why actually our models then generalize across populations, and I'll show you examples of this, and they generalize from the research to the clinic. So then we move on, we have the feature space, we move on to these classifiers. We work at what we call a metric learning space, and we learn to separate as much as possible two classes, the class of stable individuals versus the class of progressive individuals. And that's what the models then give us, and that is really the interpretability of the models. We look at what did we put into the models. We put in gray matter atrophy, we put beta amyloid, we put APOE4, and we ask the model to tell us which one is the predictor that contributes the most to this classification. And you see here that beta amyloid no surprise, is a very strong marker. But again, for us, it's really important in terms of the interpretability of the models. Now, the question then we ask is, well, could we build models that actually, at a very early prediction, they can make this stratification of patients, but without expensive, costly, invasive data? Getting PET scans, they are radioactive, they are very costly. If we can avoid them, that will be amazing. So what we ask is, can we build models simply based on cognitive data? And what we see is then that we have scores based on memory tests, for example, that they will drive the prediction of the model. Now, the answer to this question is when we put in biological markers, our models can go up to 91% of accuracy with similar specificity and sensitivity. When we work only with cognitive data, that drops down to about 85%. If we add to this model gray matter, that goes up to 88%. So there is definitely value in adding biomarkers. But at that very first screening, the very first visit, we can quite reliably, at about 85% accuracy, stratify people into stable versus progressive, and we can then move on to a further clinical diagnosis and diagnostic pathway. And I'll show you a little bit more about how we work with these models. So the next step, as I said, is we really want to personalize this diagnosis. We don't want to stay at that kind of two-class problem. We want to be able to look at individual health trajectories. And what we do is we pull out a marker from the model, and that's a multimodal marker that allows us to investigate whether the patient will remain stable or not, but also whether how fast the patient is moving from stable health to disease. And what you see here is if we plot this marker across individuals against memory decline, what you see is that there is a very strong correlation when we use cognitive data for the model or when we use biological data. Pretty much, the higher the marker, the stronger the decline that we see. Then we will go on to validate this marker with biological data because we need to make sure that what we have extracted from the model as a decision marker is really reliable against what we know for pathology. So we validate it against beta amyloid, and you see the higher this prognostic score that we get from the model, the higher the amyloid accumulation, the lower the gray matter density, so higher atrophy, higher prognostic score, and also a higher prognostic score is associated with positive APOE4. So this model-derived marker that we now have is validated against cognitive decline and against pathology markers. So the next question is, how can we use now this marker that we have validated to stratify individuals? And what I show you here, this is still in the research space. We took the research data from many different cohorts. And we asked the model to give us this prognostic score, this prognostic marker for each one of these individuals. And we plot them here. That's what you see here. And based on normative data, based on all of the work that we have done before on previous cohorts, we can separate them in three classes: stable, slowly progressive, and rapidly progressive. Now, the interesting thing is then we open the clinical labels. We look at clinical outcomes and diagnosis. And what you see is that the model gives us high scores for patients that have already been diagnosed with Alzheimer's, while these scores shift a bit to the left. They are lower if we are at the early stage of Alzheimer's. And the scores look like totally stable if the patients do not have dementia. So for us, this is great validation. We didn't look at the clinical diagnosis at all. We have people from different research cohorts. We ask the model to predict, to give us this prognostic score, and then we validate that against clinical labels. But the most exciting space is this pre-symptomatic space. This is data from cognitive normal people. Usually these people are involved in cohorts, they're engaged in cohorts, they participate into the whole kind of clinical battery that is run on patients, but they don't have symptoms. And what you see here is that some of these patients, or not patients, some of these volunteers Actually, the model predicts that they will remain stable, no pathology, but some of them, the model predicts that they are slowly progressive. Is this the space of brain health checks, maybe one day, where with very little non-invasive data, maybe even digital markers that we can put in our models, we can be predicting early whether people might be slowly moving towards pathology? And would this be the space when people are still young, not affected by disease, when there is no damage yet done into the brain, that we can intervene with even simply lifestyle changes to change that pathway, to change that health trajectory? So now the next step for us is we build these models. We show that we can actually reliably predict and develop prognostic markers of disease, of pathology. We can reduce the risk of misdiagnosis with these models, and we can stratify patients precisely. But all these models are still in the research space. So you could say this is all built with cohorts of individuals, of volunteers and patients that maybe they are the more educated, maybe they are the more willing. To be able to make a difference, we need to take this into clinical practice. So we need to test the clinical utility of these models. We need to know whether we can put them into memory clinics and change the clinical pathway. We need to know whether we can put them into pharmaceutical trials, clinical trials, and potentially enhance their efficiency. And maybe one day we can put them as early as brain health checks. Now, what we believe that these models can do based on this kind of prognostic capacity is they could allow us to re-stratify people, not on healthy versus disease, but based on their diagnostic pathway, how fast potentially they are moving towards disease. And this could really change how clinicians then make recommendations. Maybe patients that fall in the stable category do not need to do all of the rest, kind of the invasive clinical diagnostic pathway. They don't need PET scans. They don't need lumbar punctures. This saves a lot of money. It saves a lot of stress for the patients. They could be sent back to the community. They could also be checked for other comorbidities. For example, they could be checked for depression. If these people have come to a memory clinic because they have symptoms of cognitive decline, but the models tell us they do not have pathology, they will not express pathology. These people still have symptoms. Maybe they have something else. Maybe they have cardiovascular disease. Maybe they have depression. And they could be directed into a different clinical pathway that can really make a difference for them. The slow progressive individuals are the individuals that we need follow-ups for. The rapid progressive individuals are the individuals where we need immediate treatment, potentially immediate hospitalization. So you know better than me, you're working in the clinical space, that if we can change this, we can make a real difference into the patient's well-being and their families and carers, but we can also save quite a lot of money for healthcare systems. So let me show you a little bit about the first evidence we have. We are very excited to be able to work very closely with clinicians. Here in the UK and in Singapore, we have put these models into memory clinics within the framework of clinical research. And this means we don't actually have the data. The models see the data. What you see here is the CUMIN-MC study. Is a study that is led by my colleague Tim Richman in Cambridge, and actually a study across memory clinics in the UK. So what you see here is the models are trained on research data, and now we give them the patient data, and we ask the models to predict. The patient data that we have are from the first visit of the patients to the memory clinic, and then referred to Addenbrooke's for a structural scan. So the only data that the model now has to make an informed decision is one brain scan and cognitive scores. And what you see is that the model says the patients that have already an AD diagnosis will be rapidly progressive. Interestingly, in the space of mild cognitive impairment, we see that the model reliably says these patients are mostly slowly progressive. And then you see here patients that have symptoms but are not diagnosed with dementia. For the model, they are classified as stable in terms of potentially no disease pathology. Now, as I said, we don't have these labels. We don't see the patients at all. The models just see their scan and their cognitive scores, and they make the predictions that you see here. So we're really excited that then these models in real patients, real-world patient data, can make this classification. We went also to extend this into memory clinics in Singapore. We have a collaboration with NUS University and NTU, and we did exactly the same in their data. You see a little bit of a different kind of clinical labels here. Really interesting, in this sample we have moderate MCI and mild MCI, and you can see how the model reliably stratifies higher prognostic scores of disease progression for the people that have moderate MCI, lower for mild MCI, and the cognitive normals, the model reliably says they are stable. So the question that people always ask me at this point is, if we gave you money to put this within a clinical trial, how long would it take until we know that actually the models make the right prediction? So if we started with patients that they are early now, they come into the memory clinic with symptoms, with mild symptoms, or actually patients that have no symptoms at the pre-symptomatic stage, how long will we have to wait to be able to validate the algorithm's predictions with longitudinal data? And the answer comes actually from the data we have from Singapore, because these are patients that have been followed for about 10 years. And what I show you here is data for about 6 years that we have managed to recover and pull from these patients. And what you see here are survival curves that effectively tell us what is the probability of conversion to Alzheimer's disease for all of these patients. And the black line that you see here is when we look at this kind of conversion based on clinical labels. So if we have the clinical diagnosis of the patients, of all of these patients, and we ask how quickly will they progress, this is the black curve. When we look at the patients that the model restratifies into stable, slowly progressive, and rapidly progressive, you see how the picture of these health trajectories for these patients is very different from this mean trajectory that we can extract simply from the cognitive, from the clinical diagnosis that we get at the first assessment. You see that when the model says that these patients are stable, when they are stratified as stable, actually clearly these people do not express pathology for down the line for about 4 to 6 years. And you see the difference here between the people that the model stratify as slowly progressive versus rapidly progressive. For us, this is really a dream come true, that actually these models can have clinical utility. They can change the way we think about clinical pathways, and they can stratify more reliably the patients than what we currently have in our hands, which is their initial clinical diagnosis. So finally, I'd like to go, if I have a minute, to the space of clinical trials. So for us, it's really important to also be able to feed these models into drug discovery. And it's a very lively space and a very exciting space to be in at this moment. So what we did here is we look at this prognostic marker that the model gives us and tested how it predicts changes in tau. Because tau is a marker that is often collected in clinical trials for drug discovery. And what we show is that this prognostic marker can restratify people and predict tau accumulation. And actually, we need 30% smaller sample size when we use the prognostic model score to predict tau than when we use beta amyloid. So this means that when we look at clinical trial data and try and stratify people based on beta amyloid accumulation, which often happens in clinical trials, we will need a larger sample for potentially to see an effect in the drugs compared to when we stratify them with this model-derived index that has seen a lot of multimodal data. So potentially, this can make a difference in the efficiency of the trials. If we reduce the sample size, clinical trials can run faster and can be less expensive, potentially giving us the opportunity to expedite drug discovery. And thanks to the Royal Society that has given me a fellowship and funding, I have been able to collaborate with pharmaceutical companies and look at data of clinical trials that have been closed, that have been unsuccessful. And what you see here is an example of when patient data that has gone into a clinical trial is stratified based on APOE, a genetic marker. You see that we cannot separate the patients. Well, we can separate the patients really clearly into slow versus progressive when we use the models, when we use the prognostic markers from the models. Now, what this allows us to do is when we split the patients into slowly versus rapidly progressive, and these are MCI patients that have passed all the criteria to go into a clinical trial, we have potentially a better way of looking at drug effects. Will this drug make more of a difference in slow progressive individuals that are earlier in the disease? It will be really great to know. It will be great to be able to put models like this in prospective clinical trials, in adaptive trial designs, and be able to really understand if we have a better stratification of the patients that go into clinical trials, whether this makes a difference to drug discovery. So I'd like to close, and I welcome all your questions and feedback by saying that I hope I have given you some evidence that with machine learning that is biologically grounded, that is clinically relevant, we have potentially the hope and the opportunity to now build tools that can help clinicians to assign the right patient to the right diagnostic and treatment pathway at the right time. We have potentially the opportunity to make a difference in the efficiency of clinical trials and to drug discovery. And most importantly, we have the potential to make a difference to the well-being of patients, their families and their carers, and also to the costs and success of our healthcare systems. So I'd like to close by thanking you for your attention, for being here today. And also I'd like really to thank the team I've been working with. I'm standing here representing a huge, amazing collaborative team of experts in machine learning, engineers, computer scientists, clinicians, neuroscientists. I couldn't do this by myself. So I'd like to thank everybody, my lab, and also the funders that have trusted us at this very early space with the taxpayer money to hopefully make a difference. Thank you.
It's a wonderful talk. Thank you very much. I'm sure there'll be plenty of questions. Right.
Thanks. Thank you. That was great. I mean, clearly that's really helpful for people that are coming to, I guess, a cognitive clinic and have got certain biomarkers that have been tested in MRI scans and things. I was just wondering what you thought the possibilities are for a unclassified neurodegenerative cohort. So essentially people coming off the street, coming to a clinic, you know, they might have Alzheimer's disease or frontotemporal dementia or progressive supranuclear palsy, and then the ability of the machine learning to separate those cohorts and say, I think this person has depression, this person has FTD, this person has AD, this person has nothing. Yeah. I wondered what you thought about the future of that.
Yeah, it's really, really amazing question. It's really the next step. So we had to start from somewhere and started from Alzheimer's disease because there's lots of data. So when we started this work, it was actually really, really hard to get access to data. Things have changed. We now have dementia platforms in the UK. We have a DDI with the Gates Foundation. The awareness of people opening their data has actually increased massively these days. And so now we can look exactly what you said. But we need data to train the models. We have, for example, started working with FTD versus AD. And we see that the markers are actually very different. And clinicians wouldn't be surprised by that. But we need the data because what the models need to learn is the separation, right? That different markers need to be combined to give us a really reliable stratification of FTD versus AD. And this is going to go for vascular dementia, Lewy body dementia, all different types, but also comorbidities like depression, like anxiety-related disorders. So it's really important to have the data to train the models. Once the models are trained, then we need to do exactly what you said, put them in the community effectively, right? In clinical practice at a very early stage where what we want to be able to see is can we stratify reliably. This will make a huge difference for treatments. We need to know, in the diagnostic pathway, what people really need depending on what type of disease. So this is really the future. But my hope is really that we can make this happen now as more and more data is becoming accessible.
Can I be really cheeky and ask a separate question?
Briefly.
Okay. I was just going to ask, is there, talking about categorization, which we've heard a lot about this morning, is there a way that actually your techniques might actually separate people into categories that we wouldn't recognize as clinicians? So not FTD, not AD, but actually completely different categories of something else, maybe tauopathies, alpha-synucleinopathies.
Yeah. So yeah, that's also the future. So this will be really amazing. And we are building other models actually that what they look is they're completely what we call unsupervised, meaning they don't use the clinical labels at all. What I showed you here is the classic kind of supervised approach where we use the labels, we test whether people are stable or progressive. But because we want to go as early as possible, people won't have labels. So the models that require that kind of supervision with labels will be useless to us. So we build unsupervised models or semi-supervised models. Effectively, what these models do is they learn patterns of data and they learn clusters of patterns of data, and they try to optimize the separation of these clusters. So then we go in and profile these clusters, and we can profile them with current clinical labels. And so we can say this looks more like FTD, this looks more like AD. But then we have these clusters that actually we don't know what they look like, and we need the markers. So we might start identifying actually new subtypes of disease. And that is really, really kind of exciting, because that means we can tailor the treatments to what people exactly need. And currently, I think that space is still very difficult. My understanding is from working with clinicians to be able exactly to see these kind of differences and separate people into different clinical clusters.
Okay, one last question, Jeremy.
Hi, I think I might, maybe I might. Hi, thank you. So how would your model perform if you took the MRI data out? And the reason I ask that is that it's based on an assumption that everyone who comes into a memory clinic needs an MRI, but that's definitely not true. And I don't think that we could justify, based on cost or environmental effects like carbon emissions, I don't think we could justify everyone coming to a memory service having an MRI scan. Yeah. And so I'd be interested to know, can your model work without that data? Yeah, absolutely. So the more kind of reliable predictors you put in, the higher the sensitivity and the specificity. We get to 92%, right? There are models at this point that can get up to 90–80%. So the accuracy of the models is improving a lot. Once you start going down to that, like least invasive, least costly space, for example, only cognitive data, what we see is on the clinical data also, because we train the models now with all sorts of different samples, we get down to 82%. Now, this is still quite good, right? What we see, the interesting thing is once we put the MRI, people shift from that space of stable towards the slowly progressive. So it becomes more sensitive, it becomes more precise, the prediction becomes more precise, right? So that's where the markers start kind of adding a bit more into the precision of the models. But you could think about a stage pathway, right? What we need to know is who is going to be stable, and we need to take them out of the healthcare system for a good while. Maybe check for other comorbidities, and then focus on those people that the model says they are progressing, and potentially take them through the more invasive pathway.